Welcome to Module 7. Module 7 is a deep dive on one of the most important parts of the screening process, evaluating lower motor neuron integrity. Knowing which paralyzed muscles can be stimulated and which ones are denervated is critical to the eligibility requirements of the study. This evaluation will also determine which muscles are good candidates for electrode implantation. We'll review how to set up and use the surface stimulator, which muscles of the upper limb should be evaluated, and how to fill out the data collection form. Because of the criticality of this step, training is not complete until key clinical competencies are met. These competencies will be assessed via live evaluation sessions with a prospective participant. By completion of this learning module, participants will identify the study time point when lower motor neuron status is assessed, identify which muscles should be included in stimulated manual muscle testing, understand the electrical stimulation parameters used for testing, identify correct placement of electrodes for radial, median, and ulnar nerve muscles, and understand the importance of applying the MRC scale to stimulated muscle responses. The stimulated manual muscle test is a critical component of the screening and enrollment phase to determine eligibility for the GRAND study. As discussed in Module 2, application of surface electrical stimulation is an effective technique for identifying lower motor neuron damage, or functional denervation. If the lower motor neuron is intact, electrical stimulation will cause a strong contraction in the paralyzed muscle. If there is partial or full damage to the lower motor neuron, the response will be weak or absent. Let's take a moment to talk terminology. There are a few different terms we use when discussing lower motor neuron damage. In addition to functional denervation, we may just say denervation. We also may refer to the excitability of a paralyzed muscle. Some may even talk about the stimulatability of a muscle, but that's not really a word. In any event, all of these terms are used interchangeably to describe responses of a paralyzed muscle to electrical stimulation. Next, we will discuss the importance of using the MRC scale, commonly used to quantify manual muscle testing, to accurately grade the paralyzed muscle's response to surface electrical stimulation. This is the well-known scale developed by the Medical Research Council, modified to reflect the application of electrical stimulation to induce movement rather than voluntary movement. For eligibility for the GRAND trial, we are looking for grade 4 and 5 responses to electrical stimulation in key muscles for restoring arm and hand function. Grading the muscles is important to ensure a functional and effective NNP system. Muscles that respond weakly or not at all indicate partial or complete lower motor neuron damage. A poor response in one or more key muscles makes a prospective participant ineligible for this study. Therefore, it's critical to master the application of surface electrical stimulation and accurate grading of muscle responses. The rest of this module will review the practical application of electrical stimulation and evaluation of muscle responses. First things first, not everyone is able to have electrical stimulation. Prior to conducting the stimulated manual muscle test, you'll need to get to know your participant a little bit. Do they have a demand-style cardiac pacemaker? Are they pregnant? If so, electrical stimulation should not be applied. And of course, avoid applying electrical stimulation over open or broken skin or near any metal elements in the arm, such as an external fixator. So, what do you need to get started? We will send you a commercially available surface electrical stimulation unit, like the one pictured here, as well as some 1 1/4 inch electrodes to get started. The data collection form will be included in the case report forms for the study. There are a few other things that you will need to have on hand. Alcohol prep pads are necessary to remove any oils or lotion from the skin, which may cause impedance and reduced response to electrical stimulation. Additionally, applying saline to the arm or under the electrodes will increase conduction of the stimulation. You may also want to have some tape or Coban on hand to hold the electrodes in place. Make sure that you start each test session with fully charged batteries. Prior to conducting the stimulated manual muscle test, you will have completed a manual muscle test of voluntary function. Information about voluntary function will help you identify the partially or fully paralyzed muscles to be tested in the stimulated manual muscle test. You will want to focus on muscles that have voluntary strength grades of 0 to 2. As you apply stimulation, keep in mind that you will be activating nerves, not muscles directly. Having a motor point chart on hand is useful to identify electrode positions for achieving the best muscle response. The next two slides will identify key arm and hand muscles for excitability testing. Data collection for the grand study combines voluntary and stimulated muscle strength on the same form. That makes it easier to identify which muscles to focus in on for stimulated manual muscle testing. Let's walk through an example. You just completed a manual muscle test on Alvin, a prospective NNP participant. You recorded his voluntary strength scores in the MMT columns. You'll note that Alvin has good proximal shoulder strength, strong elbow flexion, and active wrist extension bilaterally. So far, he seems like a potentially good NNP candidate. However, you need to make sure that his muscles respond well to electrical stimulation. What muscles should you include in the stimulated manual muscle test? You correctly decide to focus on muscles that are weak or completely paralyzed. In other words, muscles that scored grade 2 or lower during your manual muscle test. Potential key muscles for the elbow, forearm, and wrist include triceps, pronator quadratus, flexor carpi radialis, extensor carpi radialis brevis, and extensor carpi ulnaris. Next, we will identify key muscles in the hand. Since Alvin has no voluntary movement in his hands, there are a number of muscles that you will want to assess in the stimulated manual muscle test. These include flexor digitorum profundus, flexor digitorum superficialis, extensor digitorum communis, the ulnar innervated dorsal interossei, flexor pollicis longus, extensor pollicis longus, adductor pollicis, and abductor pollicis longus and brevis. These are the key muscles to target for hand grasp restoration with the NNP. Next, we will review the processes for testing excitability in stimulated manual muscle testing. There are a few things you'll want to do before starting the stimulated manual muscle test. Of course, it's best to do this prior to the participant's arrival. Check your stimulator to make sure all of the settings are correct so you are ready to go. The unit should be set at a maximum stimulus of 100 milliamps, 300 microseconds at 30 Hz. Remember, if the stimulus is a balanced biphasic pulse, activation occurs under both electrodes. That means testing is more efficient and you don't have to worry about which electrode is the anode and which is the cathode. Don't forget to make sure that the batteries are charged. When starting the stimulated manual muscle test, there are some steps to take to ensure that you are achieving the best electrical conduction through the skin to the nerve. First, clean the surface of the skin with alcohol. It's useful to have some alcohol prep pads on hand for that. This step removes oils from the skin that may impede or block conduction. Then, paint the skin surface or the electrode with saline. Frequent reapplications are necessary, especially when moving the electrodes frequently, to ensure the best electrical conduction is maintained for activating the nerves. Two different approaches may be used for identifying innervation. The most common approach is placement of the electrodes near the muscle's motor point, where you are likely to get the highest excitability of the muscle in the absence of lower motor neuron damage. Alternatively, electrodes can be placed along the path of a nerve, more proximally in the arm, to recruit a number of muscles distally. For example, stimulating more proximally on the median nerve can recruit PT, FCR, FDS, and FPL. Keep the following tips and tricks in mind while conducting the stimulated manual muscle test. Always alert the participant before starting stimulation, especially for the first time. Encourage your participant to speak up if something hurts. As you are intently looking at the arm or hand for a good response, you may not see your participant grimacing in pain. Therefore, it's critical that they vocalize any discomfort. Also, be sure to stop stimulation before moving the electrodes. That will prevent you from vocalizing discomfort. Wearing gloves is helpful to prevent you from feeling the effects of stimulation. For a better response, gently press on the electrodes to activate deeper motor points. Finally, when keeping the electrode in place, glide the skin around the motor point for better responses. When doing this, the contact between the skin and the electrode is maintained. Do not slide the electrode across the skin. There will be an example of this in an upcoming slide. The rest of this learning module will demonstrate application of electrical stimulation to the arm and hand, starting with the triceps and moving distally. Here is an example of excitable triceps. You will note in this first video that elbow extension was assisted by gravity. In the second video, we rotate the participant's shoulder so that the triceps are extending against gravity. Keep in mind that if triceps are denervated, you may actually see elbow flexion from the radially innervated brachioradialis, if that's intact. Also, while you are activating the triceps, keep an eye out for the distal radially innervated muscles of the forearm and hand, such as ECRL, ECRB, EDC, and EPL. Here is an example of our attempt to stimulate extensor carpi radialis longus and brevis. In this video, you can see some activation of the thumb and finger extensors, then the supinator, but no movement at the wrist. It's important to palpate the ECRL and ECRB tendons at the wrist during stimulation. In the second video, we moved the proximal electrode slightly, but had the same response. These videos demonstrate functional denervation of ECRL and B, which is unfortunately common for participants with motor C5 function. Keep in mind when testing for ECRB and ECRL that EDC can sometimes extend the wrist and the fingers and masquerade as a wrist extensor. That is why it's critical to palpate the wrist extensor tendons to confirm activation. Here is an example of electrode positions used to activate the key muscles for opening the hand, EDC and EPL. Often, activation of EDC results in a claw pattern where the MPs hyperextend. Blocking the MPs during stimulation allows you to see how well EDC pulls through to extend the PIPs. In some cases, gentle pressure on the electrode over the EPL is necessary to successfully activate the motor point. You will note in this video that we were able to recruit supplementary muscles, EIP and ECU. EIP may be transferred into another muscle that presents as denervated. For example, if EPL provides weak or absent thumb extension and EIP has strong response, then a stimulated tendon transfer of EIP into EPL might be warranted. While this will not restore voluntary function, it means that an electrode can be placed on EIP, which, when transferred to EPL, will provide thumb extension when activated by the NNP. Prospective participants present with different responses to stimulation. Here are two examples of surface stimulation applied to EDC and EPL. Video 1 demonstrates the technique of gliding the skin around the motor point without removing the electrode or sliding it across the skin. This technique allows you to see the response to stimulation more easily without having to stop stimulation to reposition the electrodes. Video 2 shows an example of radial nerve stimulation to activate a number of muscles concurrently. In addition to elbow extension, we also see the fingers extend, and then the wrist, and the supinator. Here is an example of stimulating the flexors of the hand. Due to the flexed resting posture of this participant's hand, the increase in range of motion from stimulation is subtle, but the response is grade 4 strength. Observe how the examiners use gentle pressure on the electrodes for better activation of deeper motor points and better index finger flexion as a result. Due to the hyperextended posture of this participant's thumb IP joint, stimulation to the FPL reduces the hyperextension, bringing the thumb to neutral. It's important to pay close attention to the passive properties of the hand during stimulation. Let's take a closer look at median nerve stimulation to activate FPL. In addition to the challenge posed by the thumb IP hyperextension, isolating FPL can be difficult due to its relatively deep motor point. As seen in the previous slide, stimulation to FPL flexes the IP joint toward neutral. This is better seen when stabilizing the thumb MP joint. Here are two other examples of stimulated finger flexion. In the first video, you see good flexion response in the long ring and small fingers. The second video shows weak index flexion and only slight movement at the long and ring fingers. Again, note how applying gentle pressure and gliding the skin around the motor point changes the response to stimulation. This video demonstrates stimulation to the wrist flexors. Wrist flexion is an optional movement that can be included in the NNP system. The ADP and ulnar innervated intrinsics are assessed by catching the ulnar nerve at the wrist and its branches at the dorsum of the hand. This video demonstrates good MP flexion in the long, ring, and small fingers, as well as activation of the first dorsal interosseous. While difficult to see due to the angle of this video, ADP is also activated. The MP flexion force from activation of the intrinsics provides a nice counterbalance to MP hyperextension that is often observed with EDC stimulation. This video has a better angle for observing activation of the adductor pollicis, which is very strong in this participant. This video demonstrates good activation of the ulnar portion of FDP as well as FCU. There are some associated forms for this phase of the grand trial, including informed consent documents, as well as case report forms for recording voluntary muscle strength and muscle excitability. Before wrapping up this learning module, it's worth noting that the hardest muscle to grade is one that has no response. In other words, is grade 0. We always second guess whether we did everything possible to activate the motor point. In addition to the usual checks, such as making sure the batteries are charged and the skin has been adequately prepped, it's helpful to apply stimulation to the nerve more proximally for confirmation of an absence response. For example, a recent participant in our upper limb clinic presented with C5 motor tetraplegia. Our team was unable to activate his radial wrist extensors, regardless of trying several different electrode placements. We moved the electrodes proximally to activate the radial nerve higher up, where we were able to recruit the triceps, EDC, and EPL. We did not observe BR or the radial wrist extensors. Observing the triceps and radially innervated muscles distal to the wrist extensors confirmed that BR and ECRL and B were denervated. These are the kinds of problem-solving approaches that will be addressed further as we work together with you while you're assessing your first few participants. By completing this learning module, you can hopefully identify the study time point when lower motor neuron status is assessed, identify which muscles should be included in the stimulated manual muscle test, understand the electrical stimulation parameters used for testing, identify correct placement of electrodes for radial, median, and ulnar nerve muscles, and understand the importance of applying the MRC scale to stimulated muscle responses. Congratulations! You have now completed Module 7. Coming up in Module 8 is an overview of the primary and secondary outcome measures that will be used in the grand trial.